So this was a 30-year-old woman who came into the office because she'd been noticing a skin rash over her eye, her forehead, sort of on one side of her face, and then also on her anterior chest. She says that she'd never really had a rash like this before, and it came on kind of suddenly over the course of a couple of days. She doesn't remember any new exposures or detergents or anything else that could have set it off. But she does remember that she had been on vacation when she first noticed it, and she was just getting back in from vacation, and things were sort of getting worse. So she'd gone to an urgent care and was told that, well, maybe this is just a little bit of like a reaction to something that you had been exposed to while you were on vacation. Like maybe you just didn't realize it, or you ate something that was new or different, and was given some topical steroid for it, which helped a little bit with the rash, but not a whole lot. So the rash, when she first noticed it, was really red. There was a bit of scaling to it, and it was very itchy, but not painful. And so I'll stop there.
Oy, wow, that's an absolutely incredible start. Thank you so much, Sonia. And I think that a rash is always tricky because it's not hard to spot one. And the key question is, are you spotting the tip of the iceberg, or are you spotting something that is merely a disease limited to the skin? And I think that's the first question often when we're dealing with a rash is this really a presentation of a cutaneous disease in isolation? Or is it simply that the cutaneous part of any disease is much more easily appreciated because of its presence on the surface? And I think that that is often hard to tease out. It's easier to tease out when visceral symptoms are staring at you in the face, like abdominal pain, chest pain, dyspnea, but more subtle systemic symptoms are much harder to tease out. And so I think that's the name of this exercise, is to say the patient isn't relaying any severe visceral concerns, but are there subtle ones that would only come up with targeted questioning? And the hard part is to know exactly, well, what kind of targeted questioning would you do, and should you do that up front? And I'd say maybe not up front. I think there's so many cutaneous diseases that are so isolated, cutaneous diseases that are so common, that you probably would focus on them, and you would use your illness scripts for those diseases, things like contact dermatitis and cutaneous fungal infections, superficial infections like cellulitis, so on and so forth. But if there's anything triggering a further evaluation, be it because the patient isn't improving based on what you're thinking, or they have an atypical presentation, you should probably ask those subtle review of systems questions. And so I think here, the lack of improvement and the persistence should prompt you to dig a little bit deeper and try to establish, is this truly a systemic disease with cutaneous manifestations, or is this an isolated cutaneous disease alone? And I'll pass the mic to Sharmi to reflect on anything else that crossed her mind.
I think like that is absolutely beautiful, Archie. My thoughts were exactly the same, to think about like, oh, is this like isolated to the skin, or is it manifestation of something else that is going on? And I think thinking about like, oh, does the itchiness of the rash helps me clinically? I think not yet. There are like certain rashes that like pruritus tends to be a very big part of it. So like, the rashes that like itch versus like the itchiness being like the big and center stage to that, it doesn't seem like that's a flavor to it in this case. And so I think just establishing a little bit more of a background, and then like the exam would be helpful to like make further diagnostic progress.
Awesome. So when she came into the urgent care, she didn't say that she had any major medical history. She wasn't on any medications. She didn't have any family history, and her health-related behaviors were notable only for consuming alcohol 1 to 2 times a week, about a drink in each sitting. She had never smoked and never used recreational drugs, nor had she known of any allergies, either to medications or environmentally. So on her initial exam, her vitals were stable. She didn't have a fever or anything else that was concerning. Generally, she looked quite well, but her skin exam was notable for a sort of red to purple rash over her eyelid and her forehead. on the right side of her face, and it extended down onto her cheek as well. And then looking at her anterior chest where she had reported the rash, it was really red with a little bit of scale over top. It looks like she was excoriating it as well. And there were a couple of sort of subtle telangiectasias around the rash. Looking at the rest of her skin, she actually had an area on the top of her back and neck that she hadn't noticed to be involved with rash. It was also a little bit more on the red end of the spectrum, not a ton of purple to it. And she had a little bit of involvement over the outer aspects of her shoulders, but nowhere else on her skin was there much abnormality. Her cardiopulmonary exam was pretty unremarkable. And her joint exam, because I'm going to do one, was pretty unremarkable. So that was sort of the point at which she was given a little bit of topical steroid, a stronger potency than just what she'd gotten before, and told to come back in a couple of weeks if things didn't get better. And I'll stop there before I take you to her next clinic visit.
Sonia, your cases are always so good. Thank you so much for presenting. How about what I would do is that just kind of think about like a skin disorder that has prominent pruritus and thinking all about her background history, and then pass the mic to RG to see where he can take us with the exam. So I think in terms of her background, like medication side effect is always like one of the big things that we want to make sure if somebody's presenting with rash. It seems like she hasn't taken any medication. I would ask about like, she might not be prescribed but over the counters or anything else during the trip that she has taken. And like the alcohol use, again, like 1-2 drinks per week. I think it's Hodgkin's lymphoma that with alcohol you can get some skin manifestations. I'll let RG to correct me because I might not be remembering that correctly. But in terms of like skin orders that I think about with like prominent rash, I think like in all comers, like if you think about a dry skin, ectopic eczema, like ectopic dermatitis are quite common. Especially ectopic dermatitis tends to be better with steroids. So the fact that that hasn't improved, it just may be the marked severity of it, and the steroids wasn't put in enough. The other thing is to think about like psoriatic dermatitis, pemphigoid disorders at times can do it too, and drug reactions that we talked about that can have pruritus. The one thing to always remember in someone who's like traveling, again, like she doesn't seem like the right demographic for it is infectious, like, lice, scabies in the population that I see, scabies is actually quite common. And like bed bugs of some sort is like my first pass thinking about rashes that tend to itch a lot. And with that, I will just pass the mic to RG.
Yeah. I heard so much wisdom. I couldn't quite put it together because of the phone call that I got, but I heard scabies, which I think is such an incredible thought and so easily overlooked, especially with something so pruritic. And I think, honestly, this kudos to you, Sonia, for picking up the subtleties in this rash. I think noticing the telangiectasias is very I think is a powerful clue because it tells you, at least hints, that there's a vascular component to this disorder. So I think what I'd be doing in real life is to be saying, well, hey, there's some things that are very telling and some things that are unusual. The telling part is that whenever the word purple or the hint of purple comes around the orbits, you should think about the possibility of a heliotrope rash and the possibility, therefore, of dermatomyositis. And the probability of that diagnosis skyrockets whenever it's a rheumatologist presenting on a virtual morning report. But in real life, a rheumatologist extraordinaire, I would say, in real life, you would be then tempered. Your enthusiasm for an interesting and rare diagnosis would be tempered by the fact that it's unilateral. But then you would move on to say, wait, I'm enthusiastic again because I see the shawl sign. The shawl sign is the involvement of the rash around the back of the neck and the anterior part of the chest. And then you might wonder, well, wait, what does the telangiectasias do? And so I think this is an interesting learning point, which is to say that the word dermatomyositis is a misnomer. I think it's probably helpful to understand that dermatomyositis is just half of the disease, and that there are actually 4 organs that are prominently involved. And the 4 organs are, of course, the dermis, dermato, and the muscle, myositis. But then 2 other prominent organs feature in a lot of dermatomyositis, and those are the lungs and the vasculature. So the vasculature really primarily refers to the incidence of Raynaud's in patients with disorders that look like dermatomyositis, and the possibility of pulmonary hypertension, and so on and so forth. So I'd say keep an eye out for the possibility that your patient has dermatomyositis when any one of those 4 organs are involved. And so I think that's the tension here is this a benign cutaneous condition that you'd refer to dermatology, or do you need to dig deeper? And I think digging deeper here probably would involve those kind of subtle review of systems questions that we were talking about. And the truth is, I don't remember them all, but I have a checklist of them. And I want to share that checklist with you all so you can use it and add to it and tweak it. I haven't turned it into a schema yet, but here it is. So an untargeted review of systems is analogous to the blind pan CT scan, a high risk of noise. But when is it helpful? Subtle or important findings. So people may not tell you about their weight loss until you ask. Some autoimmune conditions, people may not tell you about their chronic joint issues, their dysphagia, their Raynaud's, their dry eyes and dry mouth unless you ask. People may forget to tell you that their exercise capacity is declining significantly because it's been happening for a long time. There's a lot of taboo associated with drugs and sex. And of course, you have to know where people have been, as you all are alluding to right now with where she's traveled. So I think these questions would shed a lot of light on what's going on now. And in all probability, you're probably dealing with a benign cutaneous disease. But I think if any of these things is positive, that might change your calculus a little bit. Alrighty, back to you, Sonia.
Archie, can I ask you a question? This is the gap in my knowledge. With dermato, is the rash pruritic?
Yeah, I actually don't know the answer to that. I'm sure Sonia can shed light on that. I'll tell you, I don't think my instinct, I think the range of pruritic conditions is so wide that I don't have, my instinct is to ignore that, but I would love for Sonia to teach us either now or if she needs to a little bit later.
Yeah, no, that totally makes sense.
Remind me later. So a couple weeks later, the patient called her PCP back because things really weren't improving. Even the more potent steroid cream was not resolving her rash. And at that point, she actually came in to see her PCP, who elicited from her a new concern of dyspnea. She reported that over the past couple of weeks, she'd had a little bit more difficulty breathing, and she developed a cough, which was not really productive, but kept her up at night. She hadn't noticed any fevers or chills or sweats, but the cough was troublesome enough that she actually had a hard time getting through her Zoom calls for her work. And so at that point, her PCP did ask her a lot of those targeted review of systems questions, found out that she wasn't having a lot of Raynaud's changes in her fingers, but she did have a new rash on her fingers, and it was painful. And actually one of the lesions was starting to open up. And so the PCP at that point asked her to come see us. And when we saw her, we repeated her skin exam. So the vitals were again stable. And although she was well appearing, she did look kind of tired to us. And she really couldn't get through a sentence without coughing. Her cardiovascular exam was notable for just a little bit of, I'm sorry, not her cardiovascular exam, her pulmonary exam was notable for a little bit of crackles at bilateral bases, but otherwise not much. And then her GI exam was unremarkable, but we noticed on her skin exam that she did have new areas of rash over her hands. And this was on the fingertips and on the palmar side of her hands. She had these red, maybe half a centimeter sized areas of papule that was actually a little bit raised. And one of them was starting to ulcerate. So there was some surrounding erythema. There was a little bit of ulceration. And the backs of her hands looked pretty good. So she didn't have anything over the backs of the hands. It was really on the palmar side. Her skin rash on her face was really starting to look more violaceous than erythematous. And it had sort of isolated itself now to her right eyelid, but she also had left eyelid involvement. And then the rash on her chest and back was looking about the same with a little bit less scaling, a little bit less excoriation. We did also do a joint and muscle exam, and her strength was intact, and her joints didn't have any evidence of arthritis. So at that point, we recommended a few lab tests and some imaging tests, and I'll stop there before I let you know what they showed.
Wow. All right. So I so how about like I'll focus a little bit on the dyspnea and then I'll pass the mic to see whatever what else RJ has to add to that. So uh, as we were thinking about like whether this is like a more cutaneous finding and our suspicion is getting more and more for something systemic going on. So now we have another finding of that is non-productive cough and dyspnea. And it seems like I was like, thankfully she's not like hypoxemic. I think with dermatomyositis, the association that I have is like ILD, interstitial lung disease that can occur. You often, when I think about ILD, I think about more like slow progressive disease. However, I think there's like this entity called the anti-MDA5. Correct me if I'm wrong. Dermatomyositis that is like just more formalin and it progresses very fast. And I think a part of that is lung manifestations too. So in someone who's just like drastically, like I think in terms of the pathology, it's just progressively quickly that like something that is on my mind. And this is one that I have a low threshold to get imaging to better characterize her lungs, thinking that this is most likely parenchymal. The other thing to think about is, a vessel involvement. With diseases, as Robbie mentioned, thinking about if there's any vascular pathology involved, and that's something to think about as well. And with that, I'll just pass the mic for RG to see what else he wants to add.
Lee, I don't know. I think you nailed it, my friend. But let's digest this slowly. Y'all, this person has ulcers on her palms. That's really rare and unusual and weird. I would say that is a very powerful finding. And I think generally, when you're thinking about palm ulceration, you should recognize that it is in a world that's much larger. And that larger world is just ulcers in general. And the reason that ulcers on the palms grabs your attention is it violates the rule of ulcers. And the rule of ulcers is that they are almost always on the lower extremities. They're almost always slowly progressive, and they're almost associated with neurologic, arterial, or venous compromise. So this is an atypical ulcer. And an atypical ulcer is often infectious or autoimmune in nature, but can be the result of atypical malignancies like Merkel cell carcinoma or ischemic disease. And that's the key question is, are these ischemic ulcerations on the palms like would occur with a vasculitis, or are they not? And I think the presence of good pulses and the lack of digital ischemia argues against ischemic ulcers. And the question is this some sort of infection, or is this some sort of autoimmune condition? And I think that the lung plus skin conditions that can be infectious in this nature is very high. The good news is Juliana is raising the possibility of syphilis on the palms, which is probably your first thought. But then when you recognize that syphilis almost never involves the lungs, that thought becomes a little bit less likely. So you're dealing with a lung and ulcerative condition with lung manifestations. And I think that's where a lot of atypical bacteria come into play, things like Mycobacterium tuberculosis and a lot of the endemic mycoses. But the location of these ulcers is actually very telling, unfortunately. And the presence of palmar ulcerations is, I think, a very, very powerful tell of what Charmaine already alluded to, which is anti-MDA5 dermatomyositis. And I think it's a great example of how you have to like step back and recognize that dermato, again, is one of those four conditions: lung, muscle, skin, muscle, lung, and vasculature. And there are a couple of conditions that are amyopathic dermatomyositis, meaning that dermatomyositis with little to no muscle involvement. And MDA5 is a classic example of that. It almost usually spares the muscle and causes a lot of skin manifestations and deadly and possibly rapidly progressive interstitial lung disease. So I think the key in this patient is to really have to leap forward towards dermatomyositis, even though there is no evidence of muscle involvement. And that is very hard and very complex, but it's hard to ignore the presence of palmar papules and ulcerations in a patient with a rash, other rash, and ILD. So I'd be moving pretty quickly towards that diagnosis, primarily because the ILD can be rapidly aggressive and fatal, and this patient's taking off already. Alrighty, Sonia, back to you.
All right, so that was exactly our concern. The first thing we wanted to establish is there an infection that will kill her before we treat her with high-dose steroids that will potentially make things worse? Or is this not infectious and then we can proceed with our usual scary immunosuppressive regimens? So we did a bunch of basic blood work. Her CBC and her CMP were actually quite normal. We got an initial chest x-ray, which was actually fine, but because our index of suspicion was high, we got a CAT scan of the chest, which did show some ground glass opacities in the bilateral bases. There wasn't any lymphadenopathy noted, and we got additional infectious testing, including an interferon gamma release assay, which was negative, hepatitis assay, which was negative. We checked for aspergillus and for histone blasto, which were both negative. And so then at that point, we sent off a specific panel looking for myositis antibodies. So notably, we did run an ANA, and the Jo-1 on that was negative, as was the SCL70, the centromere antibody, Sjogren's A and B antibodies were negative, double-stranded DNA, all of the stuff that we sort of think of as subserologies on an ANA came back negative. But her myositis-specific antibodies came back positive for MDA5. So you guys got it exactly right. And we treated this patient with high-dose steroids, and we were actually sort of torn between whether or not we should admit her because she was having such significant coughing from her lung disease. But we ended up treating her as an outpatient, and within a week, she actually improved significantly. Her breathing improved, she wasn't coughing anymore, the rash was starting to go away. And so then we sort of thought about, well, okay, we can't keep her on high-dose steroids forever. And because she had concomitant lung disease along with her dermatomyositis, we did put her on rituximab, and she did quite well with that.
Sonia, this is an incredible, absolutely incredible case. There's so much learning within it, let alone just saying the words dermatomyositis over and over again with no muscle involvement. And I think just the way you presented it really set us up to reflect hard on how we can get there. And I also just want to acknowledge that randomly on a Thursday morning at about 8:40 a.m., Charmaine's like, oh yeah, this is probably MDA5 dermatomyositis, which is so cool and really, really cool. So yeah, I learned a lot. I think it's just humbling. That somebody minding their own business on a vacation, like relaxing, can then boom, abruptly like get a potentially rapidly progressive, serious disease like this. And I think kudos to you guys for recognizing it so quickly, and kudos to Charmaine, your regular old general internist who can sniff out MDA5 dermatomyositis.
Robbie just gives me too much credit. Definitely in my illness group was just like rapidly progressive ILD with like the rash, and totally forgot about like the ulcers. So thank you, RG, for reminding me of that. And Sonia, you're absolutely amazing. Your cases, I always learn so much. Just to come back to the pruritus question, is that something that you've seen with the rash of dermato?
Yeah, so that actually stumped us, and that's why we were like so concerned about a potentially infectious etiology, because typically you don't see a lot of itching with a dermatomyositis rash. But I mean, in her case, obviously she did have it, and so there's always an exclusion in medicine. There's the exception and there's the rule. But the other thing that sort of made us concerned before her heliotrope rash started involving both sides of her face was the unilaterality of it. So we were also kind of concerned about an infection because we were thinking about viral reactivation syndromes and things like that could, maybe this was a dermatomal presentation, and the itching sort of made us think more in that direction as well. So it definitely stumped us for a bit there. And actually, until she started to have this really, really quickly progressive cough that got so much worse really over the course of 2 to 4 weeks. And, seeing that almost pathognomonic manifestation of the MDA5, those were the things that really made us feel a little bit more comfortable saying, okay, well, maybe this is an infection and let's do our due diligence and rule it out. But we got to sort of get on the boat of treatment sooner rather than later.
Yeah. Oh, beautiful, Sonia. Thank you so much. Yeah, when you said the CT scan and it was like GGOs in the bases and no evidence of fibrosis, I was like, woof, hopefully this can be reversed with some good steroids. um, thank you all. We really appreciate you, Sammy. And I think like Shemo started the teaching point and Sammy finished it. So thank you, Madalena, for scribing. You're so fast. I'm so impressed by your typing. And Sammy, take us away.
Yeah, thank you everyone for this great discussion, and Sonia, thank you so much for this great case. And I am also always thinking that Madalena is typing so fast. I always want to try to help her with the scribing, but she's just she doesn't need any help. So I will just go over some quick teaching points. Actually, there were a lot of teaching points. I just see it was like 25 minutes and the whole page is full. Whenever we see rash, we should consider the possibility that it's only the tip of the iceberg and should think, is it only limited to the skin or can it be caused by systemic illness? Also consider the possibility of the rash being caused by excessive pruritus. And then you should go down the differential diagnosis of systemic pruritus. For example, when people are very pruritic, they itch and then they get excoriations and you think that's the primary rash. So we shouldn't fall into this trap. Then we can differentiate between an outside job, for example, contact dermatitis, superficial infections, cutaneous mycosis, versus an intern job. When we see any signs of visceral, more systemic involvement, for example, seen in infections, autoimmune diseases, or hematologic malignancies. Charmaine taught us that whenever we think of a pruritic rash, we should think about dry skin, scabies, medication side effects, urticaria, atopic dermatitis, and also dermatitis herpetiformis dura can also cause it. That is seen with celiac disease. Whenever we think about purple orbits, type 1 thinking makes us think about the heliotrope rash seen in dermatomyositis, and it typically spares the nasolabial folds. No, that's wrong. It does affect the nasolabial folds. In lupus, it spares the nasolabial folds, and that's sorry for my ending. I'm wrong for my ending. Then we can also see gutteron papules, mechanic hands, the shawl can affect the skin, the muscle, the lung with ILD, and also the vasculature, for example, with Raynaud's or pulmonary hypertension. I also want to share a random pearl on how to differentiate mechanic hands seen in dermatomyositis from mechanic hands from people that really work with their hands. Usually when you have trauma to your hands, it happens to the tips. And when you have ulcers and nodules on the lateral sides of your fingers, this points more to a sign of dermatomyositis. Whenever we think about ILD, we think about usually a subacute to chronic disease, but certain forms can also lead to rapid progressive pulmonary failure, for example, seen in anti-MDA5 dermatomyositis. And it's usually associated with amyopathic dermatomyositis, so CK and aldolase can be normal, and it's also less likely to be associated with cancer in comparison to other dermatomyositis forms. Then Ravi taught us that whenever we see palm ulcerations, we should think that they violate the rule of ulcers. Ulcers are usually seen in the lower extremities and are associated with vascular neurologic disease, for example, venostasis or diabetic foot ulcers. And when we see palm ulcerations, we should consider vasculitis, cutaneous cancer, and also endocarditis. When we think about lung and skin, we can think about infectious causes, for example, TB, endemic mycosis, and also nocardia, but also autoimmune, especially the anti-O1, MDA5 antibody-associated dermatomyositis. And also Sonia shared a great pearl at the end that dermatomyositis usually is not itchy and is bilateral. So we should never exclude a diagnosis due to single findings that just because they don't fit well, and go on with our differential diagnosis. So thank you, everyone. I hope you all had a good time. I certainly did, and see you all tomorrow.
Sammy, that was so great. Love the pearl about the mechanic hands. That was fantastic. You all are the best. I learned so much every single time. Have the most wonderful day. We'll see you tomorrow for some RLR. Bye.